Okay, so welcome everybody to the Teaching Value and Choosing Wisely podcast and video series. Every month we have the opportunity to talk to a leading thinker from the United States, and in many cases, and including today, from around the world, about ways of improving healthcare. And we think about that in terms of all the different dimensions, from improving affordability to safety to patient experience. And our guest today adds yet another dimension in terms of thinking about prevention in particular. My name is Neel Shah. I'm hosting this month. I am the executive director of Costs of Care as well as a professor at Harvard Medical School. And our guest this month is Dr. Rami Farraj, who holds a number of very impressive titles. He is an internist at the King Hussein Medical Center in Jordan. He's a private physician to His Majesty King Abdullah II of Jordan. He's also the chairman of the board of directors of the Royal Health Awareness Society. And we're going to be talking to him specifically today about a program called the Prevention Prescription Program that he's implemented throughout his country, I believe. So welcome, Dr. Farraj.
Thank you, Neel. It's a pleasure to be here. I appreciate it.
So I see that you wear a number of hats. Maybe just to help get everybody oriented, you could just explain a little bit more about your role as a practicing clinician and also as a health system leader in Jordan.
Okay, a bit of a background. I'm a British graduate and I did my internal medicine residency at Mayo Clinic in Rochester, Minnesota. Back in 2005, we established the Royal Health Awareness Society because we felt that there was a bad need for health awareness in Jordan that I noticed was missing from my experience in the US and the UK. We worked a lot on awareness in the beginning, but to be honest, we failed miserably. We realized that awareness alone is not enough. You have to do programs that actually change behavior. If you don't change the behavior, just being aware that smoking is bad or that, too much sugar is not good for you is not enough. So you have to put in specific programs that actually try to change the behavior of people. And we have found out that actually works. And one of those programs is what we call the Healthy Clinic program, which has the prevention prescription as part of it.
Great. Yeah, I have a colleague who says that there are basically two sources of human fallibility. One he calls, and both of them sound harsh, but one he calls ignorance, which is lack of knowledge. And the other he calls ineptitude, which is failure to execute on the knowledge that we have. And so it's a point well taken that, awareness only gets you so far, and it's that behavior change that is often the hardest component, but clearly necessary. And so maybe we can get into some of the details then. So the formulation of the prevention prescription as an idea, maybe you can give us some context about that framing even and why you chose that.
Well, Neel, you know that doctors have a big influence on their patients. They're a trusted person usually in their circle. Studies have shown that if a doctor says stop smoking in his appointment with his patient, 10% stop. And that's a big deal. We don't emphasize it enough, but that's actually a big deal. So I thought, well, what if the doctor said more than stop smoking? What if he said, how about you eat healthy food? How about if you exercise? How about, and go in more details about it, because just saying the words are not enough. So there came the idea that the doctor needs to be more of a life coach more than a doctor, and to be more involved in the personal life of his patients. And to be honest, that really worked well because it kind of improved the patient-doctor relationship that has been affected a lot recently by technology and the moving pace of our world. So we felt that if a patient comes in to see his doctor, and let's say he has a cold, instead of the doctor saying, here's a prescription for something, and you take it, and then you go. And then he will also say, here's a prevention prescription, and you have to do these special interactive sessions about your diseases that you have, the chronic diseases that you have, here in the clinic, done by me and my nurses and dietitians that come over to help you get more in control of your chronic illness, and to be more aware of what you have to do to make it better. And that's where the idea came. So we actually made a prescription pad. It's called prevention prescription, and the doctor kind of ticks on it what sessions that he feels the patient needs, so that these sessions can be given to the patient.
Well, there's a lot to dig into here, but I think some of the dimensions of this that seem very compelling is that a lot of the modern healthcare delivery system is really optimized for acuity. So you can imagine that somebody who comes in with a, like a cold and wants an antibiotic, or they want their immediate problem solved, and that's often what we feel like we're doing in our clinical encounters. And part of the potential benefit of this is that it sort of builds out room and space so we can deal with some of the chronic conditions and provide some more incremental type care as well. Another dimension of this that comes to mind is, you talk about this, when I initially read about your program, I primarily saw it as an intervention for patients, because there's sort of infrastructure and programming that you can direct patients toward. But I wonder, and I'd be curious about your opinion, if to some degree this also is an intervention for the physician, because as you say, simply asking about smoking is a key lever in smoking cessation, and maybe that by structuring a number of preventive care options, you're prompting appropriate questions.
Oh, absolutely. Absolutely. We found more interactions from the doctors and nurses that were involved in this program in the prevention issues. And when you have something to offer, you'll talk about it. I mean, I understand that a doctor's clinic is busy, and he's not going to spend 20 minutes talking to you about what food you're going to eat every time you come in. But if he can give you a prescription that you can go and attend a prevention session about this topic in his clinic, then he would. And the beauty about this is that there's some social pressure that is applied here as the relationship and trust develops between the patient and the doctor, so that if the patient does not attend, especially in rural areas where everybody knows everybody, there's a bit of a social pressure that, I gotta attend this session before I see the doctor, because I have to show him that I have attended, because he's gonna ask me next time I get my high blood pressure medication if I attended the course or not. So there is a bit of a social pressure which we use to the advantage of the program, but it has definitely made the doctors and nurses more involved in prevention care as well as the patients.
So I do want to probe this idea of social pressure in a moment, but first I just want to make sure that our viewers and our listeners have a full sense of what this program is. So my understanding of the program is that you've basically created time and space and infrastructure for educational programs around prevention in a number of different dimensions of health, from hypertension to diabetes and number of other dimensions. And the way it works is that there's essentially a checklist of a number of different items, and then the clinician can customize by checking off different things for the patient. Is that correct?
That is absolutely correct. We work with the Ministry of Health, so we don't create new clinics. We go to where the patient gets his usual medication. So we worked with the Ministry of Health to develop what we call comprehensive healthcare centers that they have, where most patients with chronic diseases go to get their medicines, and for primary care mainly. So we go to each center, we change it around, We create teaching sessions area. If there's an area that we can do for exercise, we will do that. A dietitian will come in, they'll give interactive sessions in the clinic. And if there's no place for exercise, you know what? One of them will put like a sash on him and they'll go for a walk around the clinic for 30 minutes. But we do what we can to make the sessions happen. But the sessions cover mainly non-communicable diseases, asthma, hypertension, diabetes, obesity, dental health, reproductive health, allergies, things that need the patient's involvement in to be a better patient and to have a higher compliance with the treatment as well. But of course, the most benefit are the ones that are about to get the chronic diseases. Those are the ones we find the most benefit. So someone who is like obese, borderline, hypertension, not yet diabetic, or maybe glucose intolerant, this is the person that has the most benefit out of this, because sometimes by just losing the weight and adopting a healthy lifestyle, he may delay the onset of these chronic diseases for years to come.
Okay, so now I'm going to warn you, I have a fairly straightforward question and then a more potentially complicated question. But the straightforward question is, in that response, one of the things that came through is just the size and scope of this program. So, which I think is at a larger scale than many of the things that we usually feature here. So can you just say a little bit about, we talk about the different dimensions of healthcare that this touches, but just how many clinics has it been implemented in, what fraction of the population does it cover, and what are some of the outcome metrics that you're seeing?
Okay, well, we launched this in 2011. Initially, we did it in one clinic for a year to test the model as a pilot program, and then the Ministry of Health came and saw the benefit and saw that they saved money as well as the patient saved money from reducing the amount of medications that needed to be prescribed because part of our care is subsidized by the government. So everyone was saving money as a result. So the Minister of Health said, you can roll out to as many clinics as you can. The only restriction is the budget restriction. We are now in 21 centers with another 52 centers that are focusing only on diabetes. We have covered roughly 14,000 people, over 9 of the 12 governorates of Jordan. So essentially, we're covering most of Jordan with this. And we would like to keep on going until all of the comprehensive healthcare clinics are covered. We're covering, there's roughly about 90 of them, so we're almost a quarter of the way through in our rollout.
Okay, that's helpful. And well, that brings me to my more complicated question, which is one of the primary barriers to implementation that I would anticipate is this idea of compliance. And you had described that part of what you're doing is creating a social contract so that there's some mutual accountability around attending to some of these preventive behaviors. And I wonder in my own practice here in Boston in the United States, whether or not, even if I had a program like this, whether or not my patients would truly follow through. And my question is, as somebody who's practiced in the United Kingdom, practiced in the United States, and practiced in Jordan, is this a approach that you think would scale not just within your country, but maybe could also work here in the States and elsewhere?
Well, absolutely. In fact, that's why we want to prove that it does. So in fact, we are currently in the process of doing a randomized study with the University of Columbia here in the US to make sure that we show evidence-based results that prove that this actually works. As you mentioned, there is an issue with the sustainability of these programs. Many programs done in the US and elsewhere have shown great results for 3 to 6 months, and then you come back a year later and the success rate is less than 5%. And I always wondered on why this is the case. And to be honest, the social contract, the social pressure that needs to be involved needs to be continuous for it to work. We don't change behavior in 3 to 6 months. We have to make it the default value. So that it takes more than a year. It takes a few years before somebody has a healthy lifestyle as his default value. And to be honest, it's quite expensive and not very useful to have it outside the clinic. But within the clinic, where people are coming in to get their medicines anyway, to get to see their doctor, to measure their blood pressure, it works. And you know, they don't have to go to a special place. They're going to their doctor. And to be honest, more importantly, the doctor is benefiting because there's this renewed respect for the physician as their life coach, like it was in the 50s and 60s of the last century. So I think it works. I think it works in many countries. Of course, each country has its own challenges, but I would like to show with an evidence-based study that hopefully will be published in the coming year or so, that this actually works. We have done a survey just to know where we're at, where we just surveyed 1,000 people, and 70% responded that that program is extremely effective. Now, I don't know how valuable that information is. It's hardly what I call evidence-based medicine, but I think we're heading in the right track. I see people now beyond 1 year that are still sticking to the program with good results and continued weight loss and continued control of their diabetes and hypertension. So I'm very hopeful, to be honest.
Well, that's great. Certainly nobody will use it unless they value it. And so those are very promising results. I want to congratulate you on this great work. I think one of the most interesting and generalizable features of it actually are how you took you know, a prevention model and then almost retrofitted it to the existing framework, the idea that, you know, clinicians provide prescriptions and that people are used to coming into the clinic for certain types of services and trying to sort of fit it all into that model. I think that's very interesting, and we wish you the best of luck, and thank you so much for sharing your insights with us.
Thank you, Neel. It's been a pleasure to be here.